Our patient is a 65-year-old obese male with a history of sore onychoxic nails on his second toes which are longer than his hallux. He has been receiving regular treatment at the Latrobe Podiatry Clinic every 6 to 8 weeks for 8 years. He has noticed sharp pains under his feet in the past 6 months due to increased hyperkeratosis buildup, which he has also been receiving treatment for during his more recent visits. The patient has hypertension, bilateral varicose veins, and bilateral hemosiderin deposits. Hair growth is present, all pedal pulses are palpable with full vascular assessment undertaken annually, with the last one taken 3 months ago with no noticeable colour change in both feet. His neurovascular status on both feet were checked 6 months previously with no insufficiencies seen. His current medications are furosemide to control his hypertension and Lipitor to control his cholesterol levels. His only known allergy is penicillin. The patient retired from working around 3 years ago as a builder and quit smoking 8 years ago, after his grandchildren were born, so as to hopefully prolong his life and be able to help care for them. He has a history of shortness of breath related to his smoking and obesity, which has worsened over the course of the past 10 years. His BMI has increased since he left the workforce, weighing close to 10 kilograms more than during his working days. He goes for a few walks a week, usually 4 or 5 short half-hour walks around the park with his wife. His footwear was heavy working boots at work, which would cause him pain underfoot and in his toes until he went home, where he would change into slippers. Now he wears Crocs or slippers around the house as they are easy to get into, and if he goes out of the house, such as for walks, he wears comfortable runners. So upon arrival into the clinic, the patient stated that he has been experiencing pain due to his thick nail in his left second toe. He's been feeling uncomfortable and experiencing mild pain under his left foot, and very slight pain has been beginning under his right foot. He also complains of having long nails, which he would like cut as he has trouble reaching them. He states that he enjoys wearing Crocs and finds them comfortable. It is noted that there is onychosis on the left and right second digits, and that all nails are elongated. Hyperkeratosis is present at the right first MTPJ, left first and second MTPJs, and the plantar aspect of the calcaneus of both feet. Anhydrotic skin is present, especially at the heel. All pedal pulses are palpable and strong, with the last vascular assessment 3 months previously showing hypertensive figures of 150/90, with a left ankle brachial index of 0.94 and a right ABI of 0.98. The ABI in this case lying in the normal value range of 0.9 to 1.3, and this indicates good blood flow to both legs. His skin colour is normal, hair growth is normal, and there are no reported neurological complaints. His footwear is appropriate, as it has a non-restrictive toe box and distributes pressure amongst the forefoot and the toes evenly, and that's for both his Crocs and his runners. The onychoxic nails are present due to the increased pressure build-up from the increased weight on the apex of the second digits, with a possible subungual hyperkeratosis present. Recurrent hyperkeratosis is present due to increased plantar pressures in these areas in the past whilst wearing his work boots, which the foot has adapted to by increasing its rate of keratinization. The nails are elongated due to the patient's inability to cut them. So we cut, cleared and filed the nails, and then we use the burr on the onychoxic nails to decrease the subungual pressure and pain. We then debrided the hyperkeratosis on the heel and affected MTPJ areas to relieve the pressure build-up being felt. At the end of the consultation, we applied sorbolene to the dorsal and plantar aspects of the foot to rehydrate the anhydrotic skin, whilst avoiding the interdigital web spaces so as to not macerate the tissue. We then educated the patient on footwear to continue his use of Crocs as they've been comfortable and seemingly appropriate. We then told the patient to visit again in 6 to 8 weeks for his routine nail and skin care. So through bearing down the affected nails, the patient felt relieved pressure subungually, which reduced pain in his toes. This treatment should be repeated as required to maintain pain relief. Wearing Crocs decreases the stress at the apex of the second digit in comparison to heavy work boots, as they are open and not hitting the ends, so continuing this footwear is important to not aggravate the onychosis. Another method of treating the onychosis would be a total nail avulsion or partial nail avulsion of the affected nails. These are surgical procedures which remove the nail or part of the nail from the digit completely, and is commonly used in treatment for onychocryptosis or to access cancerous tissue. In this instance, a TNA or PNA would be far too invasive for the patient, as a relatively simple burr treatment suffices to relieve pressure, and there are no potential complications such as infection and increased sensitivity to trauma had a PNA or a TNA been used.